And we're back with my favorite show, sitting here with myself, Greg Riccardi, Dr. Richard Call, and our special guest, Dr. Doug Spiel. Am I saying that right?
I think you said it great.
Oh, good, because, you know, people misspell or missay Spiel. They say Spiel, and I mean, not in terms of a name, but when they're talking about, I mean...
But you've got a great radio voice.
Do I?
Yeah,
Oh.
Yeah, you've got a great radio voice.
Thanks.
But listen, let's cut straight to the chase here, because I know that there's so much we got to cover.
That's right.
And I wanted to get back to the business or the calling of medicine, and the speciality that Doug is involved in, which is mine. And he's been working diligently on finding techniques and ways of treating pain syndromes that were otherwise difficult to get to. So, for example, somebody who has what's called a pelvic pain syndrome, so the lower abdomen, the pelvic region, it's difficult to really know sometimes what's causing that and how to treat it. And you know, what we used to do in the past was sometimes just do one-off injections and put some medicine in and hope for the best, and medicine would dilute away and the patient really wouldn't be any better. What Doug has done, which is I think a brilliant idea, is come up with a intelligent catheter that is threaded under fluoroscopic guidance into the affected region of the plexus, so the nerves that innervate that area and are involved in the pain process and are involved in the generation of a syndrome that we call complex regional pain syndrome. He has invented and come up with a catheter that can go in, through which you can have long-term injection of anti-analgesic agents that will minimize the level of pain. So, saying that, I'd like Doug to talk a little bit about this.
You know, you said that very well. So, as we interventionalists look at the spine and in the nerves around the spine, there's two major things we have to decide upon. Number one, is there an anatomic basis for the pain? Is there something that's hurt that we can fix? And frequently there is. There's a herniated disc, there's pressure on a nerve, there's a broken foot that we cast. The second problem, is there a neuropathic aspect to your pain? Is for some reason the nervous system, which should be in homeostasis, not functioning normally? And so there's some form of upregulation. And in many of these pain syndromes, what we're seeing is the insults that originally occurred and caused the pain have become far remote instances. And what we're left with is a nervous system that's essentially painful, where pain is the problem. Pain is protective. If you're an animal and you slice your foot, you shouldn't run on that foot. And the pain has a protective effect on the body. After a while, if your pain is simply due to abnormality in the nervous system, that should be quiesced. We should quiet it. And as Rich aptly said, there's a number of ways to do so. One of the ways is we can do repeated blocks, and we stick needles in portions of the body, and we introduce an anesthetic or a numbing agent to try to turn off the nerve. And there are sequential type blocks that we do in many instances. The key problem is that it takes a certain amount of time to make benefit of the neuroplasticity of the nervous system. The nervous system can be reset. And what I mean by that is just because your radio is running at a 9 or a 10, there's a way to turn down the volume switch. And in much the same way, we can turn down the volume switch of your nervous system. Many of the things that we have in many of these peripheral syndromes used to be known as RSD, reflex sympathetic dystrophy,
right.
Complex regional pain syndrome. And when I looked at the pelvis, complex chronic pelvic pain, I see it as an analogous situation as we see with arms and legs of people who have RSD. And so I said, why can't I shut down the nervous system there? Now, about 20 million Americans, mostly women, have chronic pelvic pain. And it starts out with interstitial cystitis, problems with the bladder, endometriosis, pelvic inflammatory disease. All in all, approximately 1 out of 7 women, which is a huge number, 1 out of 7 women between 18 and 50 have chronic pelvic pain. They have pain that lasts at least 2 weeks out of every month for 6 months. It's a tremendous amount of people. And what I found was that some sequential blocks over time can turn down the pain. Why not create a catheter which when placed and attached to a reservoir, which is an area that holds a bunch of medicine, and then a pump, why can't we just infuse the medicine over 7 to 10 days, turn the pain off, and then remove the catheter?
Yeah.
The reason we couldn't do that before is the catheters move. And why it's important is when you're putting a medicine on a nerve, you want to put it right on the nerve.
Right.
It's not a hand grenade.
Yeah.
If it's in the room next door, it doesn't work. So what I created was essentially a tined catheter, which looks very much like an arrow. And when you pull out the stylet, which is the inside portion of the catheter, you're left with a rather rubbery device with tines on it.
Right.
With the end of the catheter, it's basically externalized or brought outside the patient, attached to a pump. Medicine is infused, and we can turn the pain off for a period of 7 to 10 days, which takes effect and utilizes the benefit of neuroplasticity, wherein we turn down the nervous system. Now, this catheter should be available to me within the next month. It's going to be known as the INTELLICATH, and we're doing our final testings this month with it.
So what do the tines do?
The tines resist motion, so that if you try to move, they keep the peripheral or distal portion of the catheter adjacent to the nerve in question. It's spring wound, so the catheter itself can actually be formed into a knot, and still the inner portion of the catheter will conduct fluid.
Wow. So now how does it work? So basically you put this in and then you leave it and you kind of,
Comes out of the body.
Administer the, right, and you put the medicine in the
The
tube and
medicine
send it
goes
out?
into the tubing, and over a period of time it drips for a few cc's an hour for every day. The bag will hold a couple hundred cc's. So in about 3 days or so, you come back, we change the bag, you go back out. In 7 to 10 days, we pull the catheter. There are other utilities for this catheter, even men.
So this is something you invented?
Yeah, I have 50% of the patent, and the trademark is INTELLICATH, and we hope to start using these in people within the next month or so.
That's great.
So it's been what kind of approval process did you have to go through?
So we're undergoing what's known as an engineering change order, an ECO. It's predicated upon a catheter that's already FDA approved. The tines itself are made out of the same polymer that the catheter is made out of, and has been approved for indwelling catheters seen in the intrathecal aspects and epidural aspects previously. So all we're changing is really the tines on the catheter.
Gotcha. Oh, so you just it's basically what it was, but you added the tines.
Yeah, the simplest mousetrap is predicated on an original mousetrap.
It's kind of like the thing you buy at the store when your sink is your drain is clogged. You stick it down, you pull it back out.
So it resists. Then after a couple of pounds of pressure, it'll pull out.
See this? I took a $1 billion idea and I reduced it to like a drain opener. So now all right, cool. So this is something you invented. It's about to go into use.
We'll follow my algorithms for it. Essentially, patients will come in, whether they're women or men. They have vulvodynia. They're unable to put in tampons, unable to have sexual intercourse. The pain is tremendous. They'll come in. We'd like them to be cleared by a urologist or gynecologist so that we know that they have benign disease. Can we treat people who've been treated for cancer? Absolutely. But we want to make sure they don't have that when they come in. They'll be triaged and evaluated. They'll undergo a physical examination, a history, and if they were a good candidate, we'll do an initial block. If the initial block is effective for a period of hours or days, then we'll schedule them and we'll put a catheter in. They'll walk around for 7 to 10 days, drop back in about 3 times over that period of time, and hopefully at the end of about 10 days or so, they should have significant reduction in their pain, which may be permanent or may just go away for a long period of time.
Gotcha. So, I mean, I come from, I don't know what we want to call it, the world of, I guess if you can say it that way, the thinking of that the body and takes care of itself type of thing, and if there's a problem, there's a reason for the problem, right? So, what would you say to someone who feels like, well, instead of like if you're just killing the pain, are you not solving whatever problem is causing the pain?
Let me just say something about that, right? That's actually
A great perspective.
No, it's not a great perspective.
Well, it's terrible perspective.
It's actually an incorrect way of looking at the process of disease and pain. People incorrectly assume that pain is a symptom of disease, which it is to an extent. However, it is a disease in and of itself, okay, that causes and leads to symptomatic changes in the cardiorespiratory system, the metabolic system, the neurological system. So pain has to be treated. If it's not treated, and you follow the body fixes itself.
Not fixes itself, but like.
Oh, it corrects itself. However,
No, not even. I mean, just saying there's a what do you call it? I don't know, like a sense or
an old wives' tale.
No, no, but not that it fixes itself, but that the pain is being caused by something. Kind of hold on. Let me tell you. Like I don't like to take cold medicine, right? Because I've subscribed to the thinking that a disease is the cure, meaning my body's trying to get something out of its system.
That's the kind
and
of
by
thinking,
taking medicine, I'm stuffing it, whatever it is, back in.
No, that's the kind of unscientific thinking that got people into a lot of trouble in the 11th century. When an injury occurs in a body, there is pain. Pain occurs for several reasons. One, it's protective, okay, so it allows the body to respond in a protective way. However, pain that goes from being acute to becoming subchronic or chronic is itself an entity that's very negative for the development and the maintenance of human health. So that pain has to be treated. And what Doug's describing in terms of pelvic pain, that's a chronic pain that's unrelenting, unremitting. And what happens to women who are suffering from this type of pelvic pain, they start to go insane. Gotcha.
Well, listen, we started a thing. I wanted to have a big fight with you, but it's the end of the show. Can you believe that? It just went like that. So anyway, if you want to contact Dr. Spiel, why don't you give us, how do you do that?
The office is 732-548-2000. The main office is 1921 Oak Tree Road in Edison, New Jersey. Or you can see us on the web at www.spielmd.com.
Fantastic. Again, I'm Greg Riccardi here with Dr. Call, wrapping up this issue of My Favorite Show.
Thank you,
See you
folks.
next week.
Thanks for listening.